I think one of the big areas is really an alternative to chemotherapy in many ways. Rituximab, although there's no really approved therapy, Rituximab is the kind of the de facto standard for, what you would start with. And sometimes, for example, in SOT, you'll combine that with chemotherapy. Other times you'll just try it out on its own. In HCT, you really can't do that very often because these patients won't tolerate the chemotherapy. They're a little bit too sick. So once they fail rituximab, there's really not many options for bone marrow transplant patients. And when you do chemotherapy, you might lose the graft, which is another reason you really don't want to use chemo if you can avoid it for those patients. So again, an alternative to chemotherapy when rituximab fails is really important for these patients, one that works and then has durability. And that's what you saw in our data. Similarly, for the solid organ transplant patients, although they can tolerate chemotherapy, and that's often used, there are some disadvantages to chemotherapy, as you know. So some patients are also in that solid organ transplant setting also quite sick, and you'd prefer not to use chemotherapy if you can avoid it. And then, of course, if chemotherapy fails, you need an alternative. So I think those different needs, chemo-free alternative, number one, and then when you are able to use chemo and it fails, what do you do then, right? Those are some of the biggest needs for these patients. And that's where hopefully that's something that Tabelecleucel can fill. I think importantly, I didn't mention one other aspect that's probably a good, important need to call out as well is kind of overall safety profile for something that treats these patients, because as you might imagine, they have a lot of underlying disease and a lot of underlying medications. So you need something ideally that doesn't have some of the drawbacks of, for example, of some of the existing CAR-Ts. So things like we've not seen cytokine release syndrome. We have no evidence of neurotoxicity. So because of all that, if you really don't need to do much, pre-treatment is pre-treatment actually is necessary. Post-treatment, you follow their vital stats for about an hour or two. And if the patient walked in to get their therapy, they're able to walk out and go back home. Again, a very different profile than many other cell therapies. And again, that's a nice unmet need for SOT patients who are often basically at home after the transplant. So that way they don't have to get exposed to other people in the hospital while they're immunosuppressed. They can just get their treatment and go back home.